All right, welcome to This Explainer. Today we're dissecting one of the absolute most, yet potentially limb-threatening injuries in pediatric medicine. It's the kind of condition that can literally turn a totally routine afternoon at the park into a high-stakes race against the clock. We are talking about the supracondylar fracture of the humerus.
So let's dive right into this with a question that honestly might seem a little counterintuitive at first. You know, kids fall all the time, right? Scraped knees and bruised elbows are practically a rite of passage for them. So why is a seemingly simple playground fall that results in this specific fracture considered a true orthopedic emergency? Well, as we're going to see, the answer lies in the really severe neurovascular risks hiding just millimeters beneath the surface of a super common childhood accident. To truly understand this, we'll map out the entire clinical journey. We'll cover the basics and demographics, look at the causes and pathophysiology, then move into the symptoms and diagnosis. Finally, we'll wrap up with the emergency medical management, along with outcomes and prevention. Okay, kicking things off with Section 1, Basics and Demographics. Let's look at the epidemiology.
First things first, what exactly are we dealing with here? A supracondylar fracture is a break in the distal humerus, situated just proximal to the medial and lateral condyles. It usually snaps right through the metaphyseal region. Now in kids, this specific area has a really narrow cross-section and pretty limited cortical support. Basically, it's a massive anatomical weak point that is just highly susceptible to fracturing if it gets hit with the right amount of force.
And because of that structural vulnerability, this specific injury is incredibly common. To put that into perspective, it makes up 60 to 70% of all pediatric elbow fractures. Epidemiologically, we see it peaking in kids between ages 5 and 10. The primary risk factors are just intense physical activity combined with that growing, relatively weak metaphyseal bone. And that combination is actually why we see boys affected slightly more frequently than girls. Now, while the vast majority of these fractures are uncomplicated, here is the real kicker. Roughly 10 to 20% of them are associated with neurovascular injury. The displaced bone fragments end up sitting dangerously close to the cubital fossa, which is essentially a crowded highway of vital nerves and blood vessels. That specific subset of complicated cases is exactly why this whole thing demands emergency intervention. Let's transition over to Section 2, Causes and Pathophysiology, to examine the etiology of how this bone actually breaks. So how does this actually happen? The absolute classic mechanism, like the textbook scenario, is a fall on an outstretched hand with the elbow fully extended. Picture a kid flying off the monkey bars or maybe tumbling over the handlebars of a bicycle. Their instinct is to just throw a hand out to catch themselves. That massive hyperextension force travels straight up the forearm and slams directly into that thin, immature distal humerus we just talked about. Combine that high-energy sports trauma with childhood skeletal immaturity, or in some rare cases, underlying conditions like osteopenia, and the bone simply snaps under the pressure. And when it snaps, it usually goes one of two ways. The extension type accounts for a staggering 95% of these cases. In this scenario, the hyperextension forces the distal fragment posteriorly, which leaves the really sharp proximal fragment pointing directly toward those vital anterior vessels. On the flip side, making up the other 5%, is the flexion type. This comes from a direct fall right onto a flexed elbow, which drives that distal fragment anteriorly instead. Knowing exactly which way the bone shifted is absolutely crucial for figuring out what structures might be crushed right beneath it. To really grasp the ticking clock aspect of this injury, doctors rely on the TAN mnemonic to map out the cubital fossa from lateral to medial. First, you've got the radial nerve, then the biceps tendon, next up is the brachial artery, and finally, the median nerve. Any displacement basically introduces jagged bone edges directly into this packed neighborhood, risking immediate arterial compression or severe nerve traction. Which leads us straight into Section 3, Symptoms and Diagnosis. Let's look at the clinical presentation when our patient actually rolls into the ER. Okay, when a patient comes in, it's obvious something is wrong. They'll have marked swelling, intense pain, and probably a very visible deformity. But the doctor's immediate focus is going to jump straight to mapping any nerve damage. If the median nerve is stretched, you'll see weak wrist flexion and a numb lateral palm. If it's the anterior interosseous nerve, which is a branch of the median, the child literally cannot make the OK sign with their fingers. A damaged radial nerve, that gives you a classic wrist drop, where they just can't extend their hand. And if it happens to be that less common flexion-type fracture, the ulnar nerve might be hit, meaning they lose sensation in their little pinky finger. This exam is basically a direct window into what is happening under the skin.
Now, of course, we have to be absolutely sure it's actually a supracondylar fracture, right? The differential diagnosis includes a few sneaky copycats. It could be a simple elbow dislocation, a fracture of just the lateral or medial epicondyle, a radial head break, or honestly, even just a really severe soft tissue injury. Because the swelling can completely obscure the exact deformity, we simply can't rely on the physical examination alone to rule these things out.
And that is exactly why the ER moves on a super strict diagnostic pathway. At minute 0, the primary investigation is plain x-rays, specifically getting those AP and lateral views. Doctors are aggressively looking for a disrupted anterior humeral line or a posterior fat pad sign, which tells us there's joint effusion. By minute 15, a highly detailed neurological evaluation is underway to check all those nerves we just talked about. And by minute 30, if there is an absent radial pulse or maybe a cold, pale hand indicating the brachial artery is compromised, they will immediately escalate to a Doppler ultrasound or CT angiography.
Once those x-rays are up on the screen, doctors use the Gartland classification system to grade the severity. Type 1 is undisplaced, meaning the bone is broken but still perfectly aligned. Type 2 means it's displaced, but a piece of the bony cortex is still intact, kind of acting like a hinge. Type 3 is completely displaced with zero cortical contact, which drastically increases the risk to the nerves and arteries. And then you have type 4, which is often diagnosed in the operating room, involving multidirectional instability. This system dictates literally everything that happens next.
Because that Gartland grade dictates the next steps, let's move into Section 4, Emergency Medical Management. Immediate stabilization in the ER is everything. First, immobilize the limb and get some analgesia on board for the intense pain. But here is the absolutely crucial takeaway from the step. The arm is splinted in about 20 to 30 degrees of elbow flexion. You must avoid excessive flexion. Why? Because bending the elbow too much can literally clamp down on an already stretched or compressed brachial artery, worsening the vascular compromise and starving the child's forearm of blood. From there, the treatment path basically forks in two directions. If you're looking at a Gartland type 1 non-displaced fracture, conservative management is usually going to be enough, just an above-elbow cast and close X-ray monitoring. But for those displaced fractures, types 2, 3, and 4, we are looking at urgent surgical management. Surgeons will typically perform a closed reduction, realigning the bone from the outside, and then use percutaneous K-wires, which literally means driving pins through the skin and bone to hold those fragments in place. If the brachial artery is still compressed or somehow severed, they have to pivot to an open reduction to physically go in, clear the obstruction, and restore blood flow to save the limb.
Finally, let's wrap up with Section 5, Outcomes and Prevention, where we'll evaluate the complications, long-term prognosis, and how to prevent this whole ordeal.
Like we've been saying, the stakes for proper management are incredibly high here. Early complications include that dreaded brachial artery injury and compartment syndrome from severe swelling. If that ischemia isn't resolved quickly, it leads to one of the absolute most devastating late complications, Volkmann ischemic contracture. That's where the muscles of the forearm physically die and contract, leaving the hand permanently clawed. Another late complication of poor bone alignment is cubitus virus, often called a gunstock deformity, which leaves the arm cosmetically bowed inward and can really mess up the elbow's mechanics for life. But despite those terrifying risks, I really want to leave you with some good news directly from the medical literature. With early diagnosis and proper management, quote, the prognosis is generally good, end quote. Even if a child comes in completely unable to make the OK sign or presenting with a dropped wrist, most of these nerve injuries are neuropraxias. Basically, that means the nerve is bruised or stretched, not completely cut in half. So with time, usually just weeks to months, they spontaneously recover and the patient gets full function back.